Private companies and public medical schools are getting together. The ties between Arizona State University and the Mayo Clinic are getting tighter.
It's a fantastic relationship where we've taken a comprehensive research university and connected it with the national leading clinic, and we found a way to take all the things that we do and all the things that they do and leverage. It's not 2 + 2 = 4, it's 2 + 2 = 7.
And the changing face of medicine in Arizona.
What we're seeing is a more nationalization of healthcare, where big companies that are successful, like Mayo or like Banner, are going to come into local hospital systems and figure out how to make a business model work properly.
The next generation of doctors and the Supreme Court and Arizona immigration laws together again. This is Arizona Week. Hello and welcome to Arizona Week. I'm Christopher Conover in for Lorraine Rivera. This year we've seen Banner Healthcare take over the hospital at the University of Arizona in Tucson. The Mayo Clinic has also formed an alliance with another Tucson hospital, and Mayo is forging an even tighter relationship with Arizona State University. We begin our look at the public-private state of healthcare with Ted Simon's discussion with ASU President Michael Crow and Dr. Wyatt Decker, the CEO of Mayo Clinic, Arizona.
We've been working closely with ASU at the Mayo Clinic for over 12 years, and it's resulted, as Dr. Crow mentions, in a host of collaborations. We have a number of nationally recognized faculty that are co-hired by the two institutions, and we have the fantastic ability to leverage the expertise at ASU for the Mayo Clinic to solve difficult problems in healthcare.
Recent developments I was reading include licensure by the State Board for a private post-secondary education. What is that all about?
So this is Mayo Medical School in Arizona in collaboration with Arizona State University. As you have probably heard, Ted, there is thought to be a national shortage of physicians, and Arizona ranks in the bottom quartile in physicians per capita for our population. So one could just stop there and you could say, you know what, we need more doctors in Arizona, let's launch another medical school. However, when you look at all the changes in healthcare that are taking place, we think there's an even more compelling need for a medical school, and one here in Arizona, and that's a school that completely redesigns how doctors are educated. And bringing the educational innovations that have been pioneered at ASU has given us a fantastic opportunity to redesign medical education and pilot that right here in Arizona.
Talk about that redesign and what will be seen here that hasn't been seen before.
So I think there's three core elements. We've built two schools that will run parallel with the medical school and ultimately be a part of the whole medical education ecosystem that Mayo is building. One is in biomedical informatics and one is in the science of health delivery. Those, think of it as computation, engineering, economics, decision making, all of the things that make medicine more effective and more efficient and more successful. And that's not just medicine in the hospital, but your health outside while you're still at home, so you're not going to the hospital, all of those things coming together. And then the third thing that we've brought to bear here is a new pedagogy for teaching. So think of it as the most advanced technology firms in the world that ASU has integrated into its Ed Plus at ASU unit, now plugged into the most significant clinic in the United States in a way in which we can have the most advanced teaching, learning, and projection tools that humans have ever developed now applied to a medical school.
And I mentioned licensure from the state. I know accreditation was not too long ago as well. How difficult was it to get the license, to get the accreditation, when, again, you're talking about something new here that maybe some folks haven't seen before?
Yes, so our team, again in collaboration with ASU, was very thorough in our application. And as you know, we run a sister medical school in Rochester, Minnesota. And so by leveraging the expertise both at ASU and at Mayo Medical School in Minnesota, we were able to basically sail through the application process. And there's a hunger from our nation's leaders in medical education, including the national accrediting body, to start creating generations of physicians that can solve our healthcare problems and not become victims of our healthcare system.
Traditional medical schools, obviously you get your medical degree after a certain amount of time and a certain amount of practice and these sorts of things.
Right.
But I noticed that with this collaboration, you can get a master's degree.
That's correct.
What's that all about?
So part of redesigning the curriculum was to free up time in the education of medical students for what we feel are elements that are as important as the traditional diagnosis and treatment of medical conditions. That's still important, but the reality is we also have a lot of technologies that now help with that. So what we've done is we've freed up the curriculum, made it far more efficient, leveraging the educational technology we were talking about, and then we've layered in experiences in systems engineering, and again, this is where the ASU expertise is really valuable, business community, social sciences, so that the physicians will, all of them in training, will get some sciences of healthcare education, but those who choose to can do a little extra work, not a lot, and get a master's degree.
You had mentioned earlier the healthcare delivery. I know the science of healthcare delivery, there will be programs involved here.
Right.
Describe those.
So we have in downtown Phoenix a new College of Health Solutions that focuses on, you got to think about health outcomes and health solutions as something that we're working toward. I think our objective, including the Mayo Clinic's objective, is to keep you out of the hospital, to keep you as healthy as long as possible, to use the hospital for major repairs. The science of healthcare delivery, the science of healthcare, the science of health delivery is all about, depending on how you look at it, is all about finding ways to make your health outcomes more successful through your entire life, through data, through education, through analytics, through clinical interactions with trained health professionals via advanced technology. So think of the most advanced technologies, the most advanced learning, the very capable clinicians and clinical support staff all coming together and creating an environment in which you, the individual, is a learner and a person benefiting from all of this in a way where your lifetime outcomes will be enhanced.
And that's me as an individual, as a patient, as someone who may not necessarily be a student in the program. For students in the program, I mean, it sounds to me like they can go, you could go off to all sorts of interdisciplinary actions
Absolutely.
here. I mean, this is not just going off and wearing a white coat and doing those sorts of things.
Exactly. So one element of the curriculum will be interprofessional learning. So we'll put the medical students together in small groups with other pre-professional students, so nursing students, pharmacy students, and give them problems to work out. Could be a patient care challenge. It could be your pharmacy costs are 50% too high and you still need to treat a population of patients. How are you going to figure this out? So they'll get both those management skills as well as the patient care skills.
Please.
Well, I just want to add that, so one of the things that's happened is that so much of our economy now is being devoted to healthcare that it's actually becoming negative to the overall economic flexibility and economic competitiveness of the country. We want outstanding healthcare, but we want it at a much lower cost. The way to do that is through finding ways to tie in lifelong learning, new ways to produce doctors, new ways for the doctors to work, new ways for the doctors to solve, and the nurses and the support staff to solve other kinds of problems. You can't do that by just approaching things in the same old way. You need whole new methodological approaches, and that's what this partnership between Mayo and ASU is all about.
July of 2017?
That's right.
All right, we'll see you a couple of times before then.
Yes,
I hope. Good to have
so.
you both here.
Great to be here. Thank you.
We now turn to Dr. Francisco Moreno, a vice president at the University of Arizona Health Science Center, to talk about the relationship between the university and Banner Health. Let's talk about the relationship to begin with between Banner and the University of Arizona College of Medicine. Banner's running the hospital, but what's the relationship between the two entities when it comes to the college?
Well, the College of Medicine continues to be very much part of the University of Arizona. This is a very close relationship between the two, the institution and the enterprise of Banner Health. That I believe comes at a very opportune time, and these types of partnership, this academic and industry partnerships in healthcare are appearing to be in vogue in a number of places around the country as a new way of addressing the successful financial survival of academic medicine as well. So we're excited about this opportunity. There's a number of significant advantages that we're hoping to really capitalize on both sides by virtue of that new relationship.
Let's talk about training doctors. Easiest question is there a shortage of doctors in Arizona?
Yes, absolutely. The state of Arizona is probably in the lowest, we're about 43rd in the nation in terms of the number of primary care providers for the state. And that is a very important challenge in terms of providing for the basic medical needs of a very large part of the population of our state. Because we don't only have a shortage of professionals, but we have also an uneven distribution of professionals. So there are particular areas within our state that are in very, very severe shortage. Luckily here in Tucson, in Pima County, we are doing about as well as the rest of the country in terms of number of doctors per capita. But if you move to the rural counties, we have only 3 counties within our state that are somewhere near the range of what the rest of the country has in terms of number of providers, but all the rest of our counties are majorly underserved.
So how do you convince students, doctors, to go into rural counties as opposed to going to Phoenix or Tucson if they're staying in Arizona?
That's a great challenge to have. What we're trying to do is you have a multi-pronged approach to trying to take care of the complex needs that we have throughout our state. Of course, we have a very large border region. We have a very large proportion of our state that is tribal land, so reservation land. We have a lot of very rural areas in our state, and frontier medicine and rural medicine are very important priorities for us. So working to promote the interest of people living within those areas to pursue health professional careers, to come to the College of Medicine, to be better prepared to compete with other applicants that come from other communities that are very privileged in terms of their ability to prepare for admission into these programs is an important part of it. Secondly, we need to have within our curriculum important aspects of content in terms of what people are going to be taught, but also the clinical opportunities for experiences that students are going to have in those communities so that they could really anchor themselves, have the experience of working with that community, and continue to have that excitement as they're going through medical education. And ultimately, also provide those kinds of experiences for our graduate medical education. So as people are going through residency, to make sure that they serve that population as well, that they continue to get training in experience, education, and service in those areas as well.
How important is diversity, and how much time does the university spend on trying to get a diverse class of graduating doctors?
Well, diversity is a major priority of the University of Arizona right now, very consistent with our new Never Settle plan unveiled by President Hart. At the Health Sciences Center, our Senior Vice President for Health Sciences, Dr. Skip Garcia, has made it an important priority to make sure that we diversify the workforce of health professionals around the state. In the College of Medicine, I serve as Deputy Dean for Diversity and Inclusion. And our job cuts across a significant number of areas of the function of the college, including, again, the recruitment, the outreach, the promotion, the support of the admissions process, the facilitation of curricular activities, and connections with our community as well, and the integration of research and study of health disparities, population health, and precision medicine that are really going to help us address the needs of the various populations of our state. You know, 2 very important priorities that we have are, number 1, to make sure that we have a class of students that have been trained in a way that will allow them to practice medicine and serve a very diverse population, but also having a composition of students that will allow us to have a workforce that will be a bit more congruent with the population of the state of Arizona is part of what we're aspiring to as well.
Mergers of private medical companies and public universities are a reflection of the changing economics of medicine. To explore that topic, we spoke with University of Arizona economist Gautam Gaurisankaran. We have seen in recent times private medical companies linking up with public medical schools. Here at the University of Arizona, we've seen Banner, and ASU is working with the Mayo Clinic. Is this a new trend we're seeing nationwide?
It's a trend that's been going along for a long time, actually. When I used to be at Washington University before I was here, and in St. Louis, for instance, about 10 years ago, St. Louis University sold their hospital system to Tenet, which is a big for-profit healthcare provider. So it's been going on a long time.
Has this changed medical education in any way? The public-private melding?
I don't think it's changed it that much because medical education is different, for instance, than say business education. So in business education at the University of Arizona, for instance, we teach business students, and we may work with companies. Students may have externships or internships with companies, but the teaching is done in-house. They're not typically doing teaching outside. Well, in medical schools, the teaching of students is done at hospitals, and they're done at a variety of hospitals that have that train medical students and later residents. And those hospitals may not be the exact teaching hospital of the medical school, but they're just hospitals that are affiliated with them. So it's a very different model of training than what we have in arts and science or business, where hospitals are much more integrated into the curriculum, and they use a variety of hospitals, not just the ones that they own.
Looking at the economics of this, we have always had in this country big public hospitals, like the one here at the University of Arizona, and we've had private hospitals, ones run by, for example, Banner. We're seeing a merger in that. Is this changing the economics of medicine as a whole?
Well, I mean, there's no question that it's changing the economics of medicine. So the University of Arizona Hospital is ultimately, it used to be run by the Board of Regents, which is owned by the state, but it didn't have a role as like a county hospital would. And if I remember correctly, they actually bought up what was formerly what became UA Healthcare South, which was a county hospital. So we used to have this system where in many parts of the country there were public hospitals that were designated more than any other hospital to take care of indigent patients, of patients that didn't have anywhere else to go because they lacked insurance. As the ACA has come into to effect, more and more people have insurance, and that role of having a public hospital take care of those patients is less and less important because we're integrating all patients into our medical care system. It's also worth noting that there are really three types of hospitals. There's public hospitals, there's private not-for-profit hospitals, and there's for-profit hospitals. So, for instance, Banner's a not-for-profit chain, but Tenet, which I mentioned earlier, I believe is a for-profit chain. So not-for-profit chains they can't distribute money to shareholders, and they get tax exemptions from a variety of state and local and federal taxes. In return, they have to provide a certain amount of charity care and have more public scrutiny of things like CEO salaries and stuff.
Is that why we're seeing groups like Mayo come into the Tucson area and affiliate with hospitals, affiliate more and more Mayo again up in Phoenix with ASU and their medical programs, Banner affiliating with the university? Is it really just for taxes for them? Is that why it works out?
No, I don't think so, because for one thing, we're not seeing that for-profits converting to not-for-profits. If anything, the trend has been the other way around, that not-for-profits convert to for-profits. I think that the U of A Health Network, or whatever it was called by the end, was losing money, right? And so that was an unsustainable position that they were in. We can't afford to have a hospital system that's losing money, and so that's part of why the regents and the university invited Banner to come in and have this joint venture agreement with them, is to come up with a business model that's more sustainable. So I don't think at all that we're seeing that nonprofit companies are coming in for tax reasons, but I do think that what we're seeing is a more nationalization of healthcare, where big companies that are successful, like Mayo or like Banner, are going to come into local hospital systems and figure out how to make a business model work properly.
Is that a good thing? Because in theory, I guess there could be less competition, or is it a bad thing? How does that work?
Well, I have a lot of concerns about hospitals buying up other hospitals within the same metropolitan area. And I have a recent paper in the American Economic Review, came out earlier this year, that shows that this leads to price increases. And people, these are price increases that are not transparent to patients, because we pay for these price increases through higher insurance premiums. There's often a lag. And it's just not obvious to us that we're paying, ultimately, we think the insurance company is a bad guy, but it could very well be the hospital. But I think that out of market mergers, well, there's possibilities of price increases, but it's not an antitrust issue in the most obvious same way, that you control more of the market for these services. So, if I get sick, a hospital in Phoenix is not a good substitute for a hospital in Tucson. So, there are some antitrust concerns, but overall, I think that it's probably a good thing to have hospital systems be more regionalized or nationalized, or more national in scope, because what's really been happening, what you see a lot of, historically, is that there's all these studies that show that best practices in medicine don't even follow from one region to another. That there's these huge variations in what people do, and what doctors, in how they treat patients. The way they treat patients in Miami is very different than in Minneapolis, and they might spend twice as much in Miami as they do in Minneapolis for patients with the same diagnoses. And that doesn't make any sense. There's people in Miami are the same as people in Minneapolis. There's not a different way of treating a heart attack. It should be the same. So to the extent that we can take best practices from one part of the country and apply them to other parts of the country, I think this makes a lot of sense. And there are also a lot of other forces like Health IT or the ACA, various provisions in the Affordable Care Act that mean that it makes more sense for hospital systems to integrate and to learn nationally from best practices.
This week, the U.S. Supreme Court refused to take an Arizona immigration case. The court's refusal means a voter-approved law denying bail to certain people arrested while in the country illegally will not go into effect. Lynn Marcus with the University of Arizona Rogers College of Law joined us to talk about Arizona, immigration, and the U.S. Supreme Court. The court did not issue an opinion on this. They just refused to take the case, which means what the Ninth Circuit ruled stands. But interestingly, in this one, we had 3 justices write a dissent. They disagreed and said the court should have taken it. This is something we don't very often see in denying taking a case.
Well, it was just 3 justices dissented, and Justice Thomas wrote a dissent saying that the Supreme Court was showing insufficient respect to the voters of the state of Arizona and the state legislature and the Arizona Constitution. For Justice Thomas, it's really a question of states' rights. And for the Ninth Circuit Court of Appeals, as I said, the issue was fundamental constitutional rights to due process.
Arizona is no stranger to the U.S. Supreme Court when it comes to immigration cases. A couple of years ago, we had a case known as Chamber of Commerce v. Whiting that we won, for lack of a better term, we being the state of Arizona. The law was upheld. What was that case about?
Well, that case involved the Arizona Legal Workers Act, which allows the loss of state business licenses for businesses that knowingly employ undocumented immigrants. And also requires employers to use the federal employment verification system called E-Verify. The court upheld that.
And then, of course, the famous SB 1070 was challenged to the U.S. Supreme Court. The state won part of that and lost part of that, and I think sometimes, depending on which side of that law you come down on personally, you talk about the win or the loss. But what happened in that case? Just remind our viewers.
Well, so SB 1070 was a farther-reaching law attempt by the state legislature to basically enforce federal immigration law by the creation of the state's own set of laws. So the court struck down 3 of the provisions. For example, one that made it illegal for unauthorized immigrants to work or apply for jobs. And then the Supreme Court left stand the show me your papers provision, which requires the police, when they arrest or detain someone, to check their immigration status. However, the Supreme Court did leave open the possibility for future challenge of that provision, and the challenges are ongoing as we speak.
So we may see those next year or the year after in front of the court. It takes a while to get those challenges to the Supreme Court.
It does.
Let's talk a little bit about immigration laws and Arizona and the Supreme Court. It seems like we keep ending up there. We just talked about 3 cases. Why do we keep ending up in front of the Supreme Court when it comes to immigration laws?
There's been a surge of state laws in the past decade or so dealing with immigration, and Arizona has been at the forefront of that. We have a particularly conservative and often anti-immigrant state legislature, but many of the states are fed up with the federal government's, the Congress's inability to overhaul the immigration system, which everyone agrees is broken. And so the states have taken matters into their own hands, and you're seeing a number of challenges in the federal courts to these state provisions. Primarily they raise 2 issues. Many of the cases, like the bail case, raise fundamental issues of constitutional rights. For example, in that case, the issue was the right to liberty, and the court said that you can only deprive a person of the right to liberty if you have laws that are narrowly tailored to serve the state's interest, in this case, the interest in making sure people show up for their hearings and don't commit crimes while they're out. But the state, in this case, applied what they called the court referred to as a scattershot approach, in sweeping in too many people, including people who didn't pose a flight risk and were firmly rooted in Arizona. So there are fundamental rights involved in many of the cases. And then the other cases, like the 2 we mentioned, the Arizona Legal Workers Act and SB 1070, raise issues of the scope of the federal government's authority and how exclusive it is, and to what degree the states have the ability to act or maneuver in the area of immigration.
And the court has been very clear when it comes to immigration law enforcing the border. That's a federal issue, SB 1070, but things like business licenses, that's a state issue, Chamber of Commerce v. Whiting, correct?
Right, so it's an issue largely of whether Congress has occupied the field. For example, with employer sanctions in 1986, Congress made a series of choices and the fundamental choice was that employers would be sanctioned and not undocumented workers. Arizona made a different choice, and that's why the court struck that down, because it was a state intrusion into the federal government's authority in the area of immigration.
And that's our show for this week. I'm Christopher Conover. Thanks for tuning in.